Good evening and welcome, everyone. Thank you so much for joining us today. On behalf of the Atlanta Suburban Alumni Chapter of Delta Sigma Theta Sorority Incorporated, I welcome you to this very important conversation. It's truly an honor to welcome you into this space for this important and empowering conversation about HIV awareness, prevention, and community health. I am Monet Williams. I am the chair of the International Awareness and Involvement Committee. And we created this webinar with one goal in mind, to make sure that our community has the knowledge, the tools, and the confidence to protect ourselves and the people we love. HIV continues to impact women, families, and neighborhoods across the city that we love so much, Atlanta, and also across this country. Now, the most powerful thing that we can do is stay informed, stay proactive, and stay connected. Today, we're going to hear from experts in the field. This information can save lives. You're going to learn facts. You're going to learn about stigma. You're going to walk away with clarity about testing, treatment, prevention, and the realities of how you can live a long, healthy life with HIV. Most importantly, you're going to leave equipped with the knowledge that you can share with your circles, your families, your sisters, your communities. So thank you so much for showing up. Thank you for caring. And thank you for being part of this movement that centers around truth, compassion, and action. So let's get started. We won't take too much time doing introductions as far as reading through bios. I'm going to have each of our panelists introduce themselves. And the question that I want them to answer as they introduce themselves is why this work matters to you personally. So let's start with Dr. Jairus Rayford.
Good evening. Thank you for having me. As you mentioned, I'm Dr. Jairus Rayford, and I'm a behavioral scientist at the Centers for Disease Control, and I work in the Division of HIV Prevention. And I've been there for the past 16 years. Nice to be here.
And why does this work matter to you personally?
Well, as a Black woman, I want all Black people to not only survive but thrive and do well. And so I'm just very passionate about the public health status of Black people in particular. So.
Awesome. Thank you and welcome. Next, we will have Timim West. Timim, welcome. Tell us a little bit about yourself and why this work matters to you personally.
Yeah, my name is Timim West, and I am a 28-year survivor of HIV. I tested when I was much, much younger. So at this juncture in my life, it's personal for me because I live with it every day. But I also see that despite some of the gains that we've made with the virus and the disease, there's still a lot of misinformation and stigma out there. So I try to put myself there as a face just to humanize what we talk about as HIV and to let people know that you can be amazing, excellent, and thrive living with the virus.
Awesome. Can't wait to hear more about your story. Next, we'll have Eric Louie. Welcome, and why does this work matter to you personally?
Thank you so much, and good evening to everybody, and thank you for joining us today. My name is Eric Paul Loya. I'm the Vice President of HIV Services here in Atlanta for the Grady Health System. This work became personal to me in 2004 when I lost my first partner to HIV, and I have not stopped working in this field ever since. The last words that my partner said to me was, "Don't let this happen again." And so I've committed my life to this work, and it's an incredibly rewarding work knowing that we are working to protect our communities.
Yes, absolutely. Thank you and welcome. And then your counterpart, your partner in crime, Arkila Henderson, welcome. And why is this work so important to you?
Yes, good evening, everyone, and thank you for having me. So my name is Arkila Henderson, and I am the ambulatory nurse manager of HIV services at the Grady Health Systems here in Atlanta. And this work is important to me because since 2009, I have been working with individuals living with HIV. I am an advocate for health justice and equity. I believe that everyone should have a fair chance to live a healthy lifestyle, and outcomes should not be determined by their race, gender, income, housing, or any type of geographical structures. And that's the reason why I'm just going to continue this work and to help to improve outcomes and equity in care.
Amazing. Also, thank you for being here. We are going to jump right in. This first segment of our time together, we're going to give each of our guests time to present a little bit. And our first guest is going to be Dr. Jairus Rayford, and she's going to talk about the current state of HIV in Atlanta. And she's going to bring us her perspective as a behavioral scientist at the CDC.
Thank you. And I'm going to come off camera just while I'm presenting so I don't lose my connection. All right, good evening. So as I said before, I'm Dr. Jairus Rayford, and I'm a behavioral scientist and subject matter expert on women and HIV in the Division of HIV Prevention at CDC. On behalf of, oh, sorry, it's not progressing. So on behalf of the Division Director, Dr. Robin Neblett Fanfare, I would like to thank you for inviting me to your webinar today to discuss the status of HIV both nationally and locally, and how we can collaborate on how to end the HIV epidemic, especially groups that are most affected. So before walking through the data on HIV, let's briefly discuss some important terminology. HIV is a virus that attacks the body's immune system. If HIV is not treated, it can lead to AIDS. Prevention of HIV is important as there is currently no effective cure. Once people get HIV, they have it for life. However, with proper medical care, HIV can be controlled. People with HIV who get effective HIV treatment can live long, healthy lives and protect their partners. Getting and keeping an undetectable viral load or staying virally suppressed is the best thing that one can do to stay healthy, as undetectable equals untransmittable. Without treatment, HIV can make a person very sick and lead to an AIDS diagnosis and death. People with AIDS can have a high viral load and may easily transmit HIV to others. Now let's explore how HIV impacts various groups. I'll be speaking a lot about HIV prevalence and incidence. So let's just make sure that we understand the difference. HIV incidence refers to the estimated number of new HIV infections in a given year, whereas HIV prevalence refers to the total number of people living with HIV, both diagnosed and undiagnosed, in a given population at a specific point in time. So by the end of 2023, nearly 1.1 million people in the US were living with diagnosed HIV, and about 13% of these individuals, roughly 150 to 165,000, were unaware of their status. While the United States has made significant progress in reducing HIV transmission, systemic factors and long-standing inequities continue to contribute to persistent health disparities. As the next slides will show, Blacks experience disproportionately higher rates of HIV diagnosis compared to other groups. This is because factors like racism, misogyny, homophobia, transphobia, stigma, residential segregation, economic marginalization, income inequality, and mass incarceration, just to name a few, all significantly exacerbate the health disparities experienced within the communities that we come from and serve. So among those 1.1 million people in the US that I mentioned a moment ago that were diagnosed with HIV, not diagnosed with HIV, but living with HIV, 27% were white, 27% were Hispanic Latino, and 39% were Black. In 2023, among those newly diagnosed with HIV, the majority were among males. And mind you, this is still national. I'll move into our more local data once I'm finished describing the national data. So across the nation in 2023, among those newly diagnosed with HIV, the majority were the majority were males and persons aged 25 to 34. While Black people only make up 12% of the US population, they accounted for 38% of estimated new HIV infections in 2023. We call this a health disparity. In 2023, the rate of HIV infection for Black females was nearly 8 times the rate for white females and more than 3 times the rate for Hispanic Latina females. In that same year, the rate of HIV infection for Black males was more than 7 times the rate for white males and 1.5 times the rate for Hispanic Latina males. In 2023, among new HIV diagnoses, the majority were attributed to male-to-male sexual contact. And the South accounted for more than half of the HIV diagnoses in 2023. When you look at racial and ethnic differences in HIV incidence in the South in 2023, the rate for Blacks was more than 6 times the rate for whites and more than 1.5 times the rate for Hispanic Latino. Now let's turn our attention to the state of HIV in Georgia with a focus on the metropolitan area of Atlanta. Data presented in this section spans the years 2015 to 2022 and was compiled and reported by the Georgia Department of Public Health. In 2022, there were approximately 64,000 people with HIV in Georgia, with the majority of those being males. Among females with HIV, rates were 3 to 11 times higher among Black females compared to Hispanic, Latina, and white females. Also, as was the case across the nation, most HIV infections in Georgia were from male-to-male sexual contact. Most people living with HIV in Georgia in 2022 were non-Hispanic Black, with rates 2 to 7 times higher than Hispanic, Latinos, and whites in ages 30 and older. In 2022, the public health districts with the highest new HIV diagnosis rates in Georgia were Fulton, DeKalb, and Clayton. Here we have the HIV care continuum, which is a critical metric in HIV prevention, care, and treatment. It measures approximate access to and use of HIV care services. As you can see in this graph, among Georgians newly diagnosed with HIV by the end of 2022, 81% were linked to care within 30 days of diagnosis. The good news is that, as shown here, all HIV care continuum measures among Georgians with HIV did improve between 2018 and 2022. Some more good news is that we can end the HIV epidemic in the United States and Georgia. We're doing that via the Ending the HIV Epidemic in the U.S. initiative, also known as EHE, which scales up 4 science-based strategies, also called pillars. They are diagnose, treat, prevent, and respond. Let's briefly walk through each pillar with a focus on Georgia. According to the CDC, as of 2024, there were 71,500 people living with HIV in Georgia. CDC's partnership with state and local health departments to expand the impact and reach of its prevention activities has led to significant progress as the overall HIV incidence in Georgia decreased by 12% between 2018 and 2022, preventing an estimated 900 new HIV infections and saving nearly $500 million in lifetime medical costs. In FY 2024, CDC awarded $42 million to Georgia organizations like health departments and CBOs for HIV prevention and care activities, including $19 million in EHE funding. So the first pillar focuses on diagnosing all people with HIV as early as possible. Excuse me. Across the country, 87% of people living with HIV were aware of their status, meaning approximately 13% were unaware and not getting the HIV care they need. In Georgia, 84% of people with HIV were aware of their status, with approximately 16% unaware and not in care. The diagnose pillar focuses on HIV testing, which is the gateway to care for people with HIV, and to PrEP and other prevention services for people who do not have HIV but could benefit from such service. HIV testing contributes to each of the EHE pillars in that it enables those who have a negative status to make good decisions, to make decisions about sex, drug use, and healthcare that can help prevent HIV. It also enables those with HIV to get HIV treatment and remain healthy for many years. And HIV testing also enables public health agencies to detect HIV outbreaks and coordinate immediate response. CDC is focused on making HIV testing simple, accessible, and routine, including self-tests via the Together Take Me Home self-test distribution project. CDC is providing free HIV self-test kits to populations disproportionately affected by HIV. CDC and partners have sent out over 1 million tests, with approximately 100,000 HIV tests provided in Georgia. The second pillar aims to treat people with HIV rapidly and effectively to reach sustained viral suppression. In 2022, 63% of Georgians with diagnosed HIV were virally suppressed, comparable to the nation's 65%. CDC is currently funding several projects that support the treat pillar, including understanding Black women's preferences for different kinds of treatment, eliminating perinatal HIV among Black women, and many more. The third EHE pillar aims to prevent new HIV transmissions by using proven interventions, including PrEP and syringe service programs. Both of these approaches are highly effective but remain greatly underused. One of the most effective tools we have in our HIV prevention toolkit, which others will talk about in a moment, is PrEP, which stands for pre-exposure prophylaxis. This is a medicine taken to prevent getting HIV. When taken as prescribed, both oral and injectable PrEP reduce the risk of getting HIV from sex by about 99%. Although PrEP is highly effective, the CDC estimates that less than 20% of Black women, for example, are aware of PrEP. Under the treat pillar, Georgia's CDC-funded HIV testing programs identified more than 22,000 persons who were eligible for PrEP in 2022. To increase PrEP uptake, CDC is focused on increasing availability and use of PrEP among populations that experience a disproportionate burden of HIV, including gay and bisexual men of color, people in the South, and Black women. Some of CDC's population-specific projects are shown here. And the final EHE pillar aims to respond early to potential HIV clusters or outbreaks. Because of cutting-edge public health approaches, we are able to turn HIV data into action by identifying areas with rapid transmission and expand resources to maximize prevention and treatment efforts. As a result, over 400 clusters of HIV infections across the nation were reported to CDC from 2022 to 2024. And I'll conclude by saying that we have reached a critical point where we have the tools to get to know new HIV infections and the data to pinpoint where intervention is needed. If we can give communities access to all of these needed resources, we can end the HIV epidemic in the US.
Wow, thank you so much. That was so informative. I have so many notes and questions. And I'm really curious to see what surprises you may have and what maybe others have. So with that said, if you are tuning in through our YouTube channel, Facebook, or Instagram, feel free on those platforms, or even in this webinar, if you've logged in specifically on Zoom, please feel free to drop any questions in those chats, and we will make sure that we get to your question before we end this webinar. Next, we're going to hear from Tim West, and he is going to talk to us about prevention strategies from a clinical perspective. And I'm going to get your
All right, here we go. And this is going to be more of a narrative journey through some images that I found that sort of connect to my experience. So before I begin, I want to acknowledge that these images that you see are there because they tell the story better than any resume or statistic could. The first image was taken when I was 27 years old. just after I tested positive for HIV at the age of 26. I'd already been an HIV prevention advocate and leader and working on a PhD at Stanford at the time. I was aware, educated, I understood the epidemic intellectually because people around me were already dying, particularly Black gay men, artists, community members, friends of friends. HIV was not abstract to my generation. And yet, awareness alone does not inoculate us against longing. That image captures the first one, a young Black queer man trying to navigate fear, desire, masculinity, belonging, and shame all at once. Because even with information, the stigma surrounding queerness, particularly in Black communities and faith communities, often left many of us starving for affirmation, intimacy, and connection. And I'll add that I'm a PK, so that adds a little bit more fuel to the fire. And sometimes that longing led to dangerous forms of fleeting comfort with men who were not always honest about their status, or perhaps were not even fully honest with themselves. So when I talk about HIV prevention, I always try to complicate the narrative. HIV isn't simply about information deficits or individual choices. It's also about secrecy, isolation, the emotional cost of hypermasculinity and toxic masculinity, the human need to be wanted and loved in a world that often teaches Black queer people to fragment ourselves in order to survive. And suddenly, everything I understood academically had become very deeply personal. So when I talk about HIV prevention strategies, we often rush immediately to the medical interventions, testing and PrEP and treatment adherence, viral suppression. And those tools matter tremendously. Science has saved lives, but after decades in HIV advocacy and community work, I can tell you, people do not engage with systems simply because the resources exist. They engage when they feel seen, safe, respected, and valued. One of my biggest barriers, and one of the biggest barriers I think in general, is trust. And I mean that personally. I contracted HIV in the context of love, desire, trust, and silence. I trusted someone who in many ways did not trust himself enough to fully live in his own truth. He was a divine brother who was more than terrified of people discovering he loved me more than giving me something I would carry for the rest of my life. And I think systems still underestimate how much shame shapes our health outcomes. Communities that have historically been neglected, criminalized, or pathologized do not automatically trust institutions. We know this from Tuskegee going forward and even before then. Black communities, LGBTQ communities, young people, trans communities, folks navigating poverty or housing instability, folk living at the intersection of all these realities. And stigma does not just operate externally. Sometimes it becomes internalized. Sometimes it settles into the body. I've had moments where taking medication every day felt emotionally complicated because the pills themselves were reminders that one moment of trust, lust, vulnerability, and loneliness became a lifelong commitment. There are days I feel grounded in discipline. There are days I fall in love, flirt, fear aging alone, or simply grow tired of carrying the psychic weight of survival. Which brings me to that second image, right? The HIV Plus magazine cover represents a turning point in my life. The moment when I began to understand that visibility itself could become a form of healing. At some point, I realized that surviving HIV and telling the truth about surviving were two different journeys. Being public about my status became part of how I reclaimed my body and worked through shame. Art became medicine, storytelling became medicine, community medicine. And that's what I learned after decades of working in HIV advocacy, spaces from Atlanta to Houston to Chicago. What actually drives engagement is relationship, not fear alone, not statistics or other things. People engage when they feel safe enough to tell the truth. And I've seen young people open up about testing, sexuality prevention, and mental health, not because someone lectured them, but because someone created a space that was safe enough that they could breathe, laugh, and be vulnerable without punishment. And that's why I often say community engagement is not just outreach, it's ecosystem building. People are more likely to protect themselves when they can imagine a future worth protecting. So their housing matters, their mental health matters, economic opportunity matters, representation matters, joy matters. HIV prevention cannot be disconnected from dignity. And medical mistrust is deeply personal for me too. I've consistently done better health-wise when I've had physicians who affirm my full humanity rather than reducing me to a diagnosis. Doctors who understand that I'm not merely a patient or a viral load. I'm someone who creates art and hip hop, poetry. I mentor youth. I experience intimacy. I wrestle with fear. I help build institutions, and I still dream about the future. So too often these systems that engage us do so transactionally rather than relationally. And that's what brings me to this final image, right? This image represents something I wish our systems understood more deeply. People living with HIV are not merely surviving, we are leading. So I stand before you today not only as a long-term survivor, but as an educator, as an artist, as a youth advocate, and an executive director working to cultivate the next generation of leaders through the Rustin Institute for Leadership Development. Too often, systems underestimate the healing power of testimony and the leadership capacity of people directly impacted by HIV. For me, testimony is leadership. And I believe our communities, especially Black communities, carry generations of silence around sexuality, vulnerability, masculinity, illness, grief, and tenderness. So I often ask myself, what becomes possible if truth itself becomes a part of our collective healing? Not just healing our personal bodies, but the healing of our collective body as Black people. If the stigma is a barrier to thriving, perhaps truth is part of our medicine. And so, after nearly 30 years of living with HIV, what still gives me hope is this: every generation continues finding new ways to love each other into survival. Thank you.
I'm sure there's a lot of claps and snaps in the audience. I think that was such a powerful story. Thank you so much for sharing your story, and I can't wait to dive a little deeper. One of the takeaways that I have for just listening to you here are some of the things that you mentioned that you experienced more than 30 years ago. Those feelings, those very feelings are likely evident in our youth today. So the more things change, the more things stay the same. So thank you so much for sharing. So vividly and being open to share. I'm going to now turn it over to our friends at Grady, and Eric and Arkila are going to share a little bit from a clinical perspective, and I'm going to get their slides up here. All right, thank you.
All right, again, good evening, everyone. So this evening, myself as well as Eric, we're going to be discussing the modern HIV treatment, as well as why do outcomes still fall short despite having excellent tools. We're going to be discussing advances in prevention and where clinical care is winning and exactly where it is struggling. Next slide, please. Thank you. So as we talk about the advancement in treatment and U equals U, due to the advancement of HIV medications, or as we like to call them, antiretrovirals, HIV has fundamentally changed to a manageable chronic condition. Most patients today can achieve viral suppression on a single dose pill. However, for those with adherence challenges, we now have long-acting injectables that are now optional for patients that will allow them treatment every 1 to 2 months, removing the daily pill burden that they may be feeling. As it relates to life expectancy that increases with treatment, according to the CDC, people with HIV who are diagnosed early and remain in care can now expect a near normal life expectancy. This is one of the most profound shifts in modern medicine. And then, of course, consistent antiretrovirals can decrease chances of perinatal transmission. So for those who are expecting, individuals who are expecting, who consistently use their resources and take their antiviral medications throughout their pregnancy, they have a reduced chance of transmitting HIV to their infants. And HIV transmission from mother to child is now largely preventable due to antiretrovirals. So let's talk about U equals U. We did hear about this earlier, and thank you so much for giving the overview about it. But I just wanted to just add to what we learned earlier is that this is one of the most important messages in HIV today. Because through the landmark studies of Partner and Partner 2, the study that it involves 75,000 condomless sex acts, it found that there was zero link transmission when the HIV positive partner had an undetectable viral load. U equals U, that is not just some slogan that has just been developed. It is actually an evidence-based finding that has been endorsed by the CDC as well as the World Health Organization. Clinical implications, excuse me, everybody. U equals U is both a prevention tool and a powerful message. Patients who understand U equals U are more motivated to engage in care and maintain treatment adherence. Next slide, please. All right, so if we have all these tools, we talk about all these wonderful things and developments, then why aren't the outcomes better? Well, let's talk a little bit about late diagnosis. So approximately 13% of people living with HIV in the US do not know their status. Many present with AIDS-defining conditions at diagnosis, meaning years of mistreatment. 21% of new diagnoses are delayed by 10 years. But by expanding routine opt-out HIV testing, that can be a critical strategy to help to make sure that people are getting diagnosed earlier so that they can get the care that they need. Access issues. So cost, insurance gaps, and geographic availability remain significant barriers. Wire and white programs funding is essential, but does not reach everyone. Rural communities in particular face limited access to specialty HIV care. Another barrier is stigma. We've heard a little bit about stigma earlier. HIV-related stigma, including internalized stigma, discrimination in healthcare settings, and community-level stigma, is one of the most persistent barriers to testing and treatment engagement. Studies consistently show stigma delays diagnosis and reduces retention in care, particularly among Black, Latino, and the LGBTQ+ communities. How do we help with stigma? Through sexual health education. I will say, and I know Eric is going to touch on this a little later, but Grady has the Teen Experience and Leadership Program, also known as the TEP program, where teenagers are able to come in and they get to learn about the care that we provide. Also, adherence challenges. So housing instability, untreated mental health conditions, and substance use disorders are among the strongest predictors of antiretrovirus non-adherence. These are social determinants of health. They cannot be solved with a prescription alone. Reinventing how we deliver care will help with this to make this much better. Health inequities. In the US, Black and Latino individuals bear a disproportionate burden of new HIV diagnosis. According to the CDC data, Black Americans account for approximately 40% of new HIV diagnoses, despite representing 13% of the population. These disparities reflect structural racism, not individual behavior. And last, let's look at fragmented care. Poor care coordination, particularly at transition of care, such as hospital discharges, incarcerations, releases, and things of that sort, leads to disengagement from treatment. Retention in care is one of the most challenging steps in the HIV care continuum. And reinventing how we deliver care, like I said earlier, also helps with fragmented care. Making sure that we have clinic hours that are beyond 9 to 5. Having access to care on the weekends, because some people work Monday through Friday. When they get off from work, they may be tired. People have school, people have their children, and other things that they're caring for. So, as clinicians, it is important for us to meet the patients where they are. And if you're at work working 12-hour shifts, you don't want to try to take a day off just to go to the doctor. So it's up to us to make different hours available for these individuals so that they can be adherent to their care. Next slide, please. All right, so let's talk about PrEP and prevention advances. So as we heard earlier, once again, pre-exposure prophylaxis, or as we like to call it, PrEP, is one of the most effective HIV prevention tools ever developed. When taken as prescribed, daily oral PrEP reduces the risk of sexually acquired HIV by approximately 99%. And for those who inject drugs, the reduction is around 74%. The current approved PrEP options are, we have two oral medications. One is called Truvada and the other one is Descovy. And then we also have a long-acting injectable called cabotegravir, which is given every 2 months and is a major breakthrough for those who cannot adhere to daily oral medications. But despite how well it can prevent HIV, PrEP remains dramatically underused. According to AIDS View, the 2024 data, uptake is significantly lower among Black and Latino individuals, the group with the highest HIV incidence. Barriers include cost, lack of awareness, stigma, and limited access to prescribers. Also, let's look at other prevention tools. We also have PEP, which is post-exposure prophylaxis. PEP is a 28-day course of antiretrovirals taken within 72 hours of potential HIV exposure, and it is highly effective when initiated promptly. Routine testing. The CDC recommends HIV testing at least once for all adults aged 13 to 64 and more frequently for those at higher risk. Condom use, needle exchange programs, and harm reduction services remain essential evidence-based prevention strategies as well. And then once again, remember, U equals U, as treatment as prevention as well. Keeping people with HIV virally suppressed protects their partners and reduce community level transmissions. Next slide, please. And now I'm going to hand it over to Eric.
Thank you, Akila. Thank you for leading us into this conversation. So I just want to share 2 quick slides with you all, and then I'm excited for the panel discussion and answering questions from the audience, of course. But really, let's talk about some successes, right? I think as we all learned about the HIV epidemic in the 80s and in the 90s, right, all that we mostly had was to provide our patients with dignity, because we didn't have tools, we didn't have the medications that we have today. So much progress has been done here thanks to critical research funded through the National Institutes of Health and other arms. So, but where we then went was to surviving. And Timon, you give such a wonderful presentation about what that meant. But now we need to move towards thriving for our communities, because as Timon said, we need to focus our patients, and we need to focus ourselves rather, on that HIV does not define our patients. It should never be more than 0.001% of somebody's existence. So how do we as a clinical care provider in our communities make access easy and minimize the burden that HIV presents to those living with HIV, as well as to those seeking prevention in order to not be affected by HIV? A couple of things that we do here at the Grady's Ponce de Leon Center here in Atlanta, as well as many other great care providers do across the country. Rapid starting a patient is really important. That means to not leave a patient waiting to engage in care, but to make the engagement quick, easy, and to not overburden our patients with paperwork. So how do we wrap around this patient and allow them to take control of their own health, right? How do we empower a patient? And that's by providing them with tools quickly and in an accessible way. Another great thing that's happening here at the Pond Center that we're very proud of is that we have grown significantly over the last several years. We now serve over 14,500 patients here in the Atlanta area between treatment and prevention. And within, and you heard this from Dr. Rayford, you heard it from Timon, viral load, and obviously from my wonderful colleague Arkila, viral load suppression is key and critical to ensuring the health of our communities. What we've been able to achieve, and I'll show this on the next slide, is by, as Timon put it, making sure that our patients are seen, respected, valued, and heard, to develop systems that work for our patients, for our community, for our friends, for our family. And so high viral load suppression is really something that we focus on because that leans into the U equals U. Over the last several years, we were able to expand HIV care directly into the primary care setting. How many folks, when we talk about stigma, how many folks know what an HIV clinic is, where people go to get tested, right? We can talk about this in reproductive justices and how that turns into a target oftentimes. The same happens in regards to stigma when we think about HIV. So here at Grady, we're continuing to integrate HIV care and prevention into the primary care space to allow our patients to not be defined by a virus. We don't do this with any other infection. It is really mostly only HIV. Long-acting therapies is something that we're really proud of. We now have over 1,300 patients on long-acting treatments and preventions, and we'll talk about that. We're actually at this point the largest long-acting treatment and prevention program in the United States. And really, the way that has been possible is by decentralizing a lot of our operations. For our patients, it's important to access the care, the preventative means when they need it, and that needs to happen in a way that is accessible to them. So again, you can do this digitally, you can do it over the phone, you can come into our clinics, and you can also get your labs or your medications from just about any of our locations in order to make it easy and convenient. We talk about transportation as a barrier. Let us, as a system, make sure that we make that easier by getting closer to our patients. And we also heard a lot about the disproportionate impact on our women, especially our Black women, when it comes to HIV. We're very proud that our HIV prevention program at Grady now serves just about 40% of all of our prevention patients self-identify as female. And that's a really, really big task, especially when you think about that over 80% of our prevention patients self-identify as Black. Now, where are we struggling? Let's be real, let's be honest, because we need to partner with our communities in order to change this epidemic. Retention and care is something that all of us HIV providers struggle with, because when life gets in the way and our systems aren't nimble, our patients struggle and will fall out of care. That also means care continuum disruptions, right? We think about what happens when somebody gets incarcerated. Their entire care continuum gets disrupted. Can they continue medications? How can we support them? We hear a lot about funding instabilities from various different levels, whether federal or state or even international. Those funding instabilities, they touch our most vulnerable patients that are most dependent on this work, the same way that it also happens to research. Beyond that, of course, scaling up, making sure that we reach the right populations, that we address the low resource settings, and that we really address the social determinants as partners to our communities is key. Monet, next slide, please. And here's what we've done at Ponce. We put our patient in the middle. We put our patient at the center of everything that we do, right? So going back to what Timon said, making sure that our patients feel seen, respected, valued, and heard means that we as a system build ourselves in a way that is most adequate for the patients that we serve. Grady has a very strong mission around this. You know that Grady Health System here in Atlanta serves predominantly the Fulton and DeKalb County area. Fulton and DeKalb, to Dr. Rayford's presentation, are the two counties in the nation with the highest HIV infection rate. How do we turn this around? I'll give a couple brief examples because I know I'm probably way over time already. So one of the things that we did is we focused on our Black women, and we said, our Black women are so often underserved. Tell us what you need. And what our Black women needed was community. As a queer male, I have a much easier way of finding community with others that are living with HIV. As a Black woman, oftentimes that's far more isolating. So what we did is we took a cohort of 100 of our Black women, and said, let's figure this out together. And over the course of 2 years, our patients reached a larger rate of viral load suppression, and they even learned to help each other. They found community. They exchanged recipes. They helped each other with housing. It is not always a system that needs to help. We need to support our communities in finding the ways that support them best. Open access, our goal program, really, really critical. Our patients can't always stick to you have to be here at 10 a.m. and if you're not here by 10 a.m., by 10:05, we're going to cancel your appointment and reschedule you. Our patients have lives. They have kids. They have struggles. Everybody who lives in Atlanta knows the traffic and the public transportation situation. Let's be realistic. So what we created was a program that basically allows our patients to say, hey, I'm going to come in Tuesday afternoon. And we're like, cool, we'll see you Tuesday afternoon. We don't make them commit to a time, but we're ready to see them whenever they show up. On the far right side, what you see is, first I want to give a huge shout out to our late great colleague, Dr. Lauren Collins. She was a pivotal member of the research community that made long-acting injectables possible here in the United States and beyond. And this speaks to the great successes. In comparison to many of the other programs across the country, we have been able to reach our community, and we have taken a risk for our community. And that meant to not only engage the patients that were already virally suppressed, but to look and speak and listen to our patients and say, hey, for those of you that have not yet reached viral load suppression, this might be the way, because we know you're struggling with how big the pill is. We know you're struggling with taking it every day and otherwise. And so partnering with our community, that's really the way that we've addressed it. So differentiated care. How do we make ourselves nimble for our community? And if you look at the graphic that is very busy in the center, I apologize, it shows you just how many programs, access pathways, submedical subspecialties, and non-clinical support systems we build for our community, because our community deserves better. Thank you.
All I have to say is wow, 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 wow. I wish we had another hour to talk through and to ask a lot of questions. I really appreciate the perspective that each of you brought to the table. So we have the data, what's going on in our local community, as well as nationally from Dr. Rayford. We heard Tim's personal story, and then we heard from Arkila and Eric regarding about what they're doing on the ground every day to make sure that access is there for people who need it the most, and that they're building systems so that we can not only take care of prevention, but we can also have that care. So I'm going to open it up to questions. And again, if you are joining us live from Facebook or YouTube, please put those questions in those chats. If you are here on our webinar, we are also monitoring the chat here, and we will get to your questions. I will open it up with the first question. Dr. Rayford, some of the striking statistics that you shared, which was one of the most surprising things to me, is that our young people are still, that rate of HIV infection is still growing among our young people. The ages 20, I think you said 25 to 34. Is that surprising to you? And what do you think it would take to actually end HIV among, not only in general, but to decrease those numbers from our young people?
Oh my goodness. Excuse me. That is a loaded, when I say loaded, meaning I could spend 30 minutes at least answering it. I'll try to be succinct. So, and I also want to make sure that it's clear, because there's some misinformation going around that, for example, HIV rates have exploded in Atlanta and things like that. And it's not so much that things are necessarily increasing wholeheartedly. We actually were seeing decreases in HIV infection in our communities as well as across the nation. COVID-19 disrupted a lot of services, including HIV testing, as well as changes in administration and the funding that came with it, where now we're starting to lose some of the gains that we had made over the span of the last decade. And so there is some bit of an uptick in certain subgroups, like, for example, youth and other pockets within Atlanta. But overall, rates have actually decreased. Now, having to answer your question, the answer, it lives in everything that everyone's already talked about. particularly, so there's that stigma that's, not knowing your HIV status, not understanding all the tools that are available to keep you healthy and thriving and not just surviving. Particularly with young people, what I personally believe can explain some of it is the fact that they didn't live in a world before HIV. I'm 50 years old. I know you can't believe it. And I remember a world before HIV. And so therefore, I also remember what the world looked like for the decade once HIV showed up. And so those of a certain generation understand, first of all, the gravity of the situation then, but we also understand all of the advancements and how we're just in a much better place than we've ever been. But young people they don't understand that. And we've done too good of a job to some degree in our advances because it sometimes communicates that HIV is not a big deal. On the one hand, it is not a big deal because you can't continue to thrive and live your life and have near normal life expectancy. However, that's only if you are knowledgeable and you understand the disease and you understand HIV testing, et cetera. And then I'll stop with one other factor, even though there are many factors to answer your question. Stigma. Stigma was mentioned earlier, and people often think of it as how someone's going to treat you, or your fear about how someone's going to treat you, or actually how you've been treated by other people, et cetera. And that is absolutely a way that we end up keeping people from coming and getting the help that they need. But also stigma, and so we address stigma by, education and all those things that are more on the individual level. But from a macro, social, structural level, we have to do a better job of for example, advertising PrEP and advertising ART to everyone, including everyone in the billboards, not just gay men or, certain groups, because it communicates to other people that this is only for them. This is not for me. This involves them. It doesn't involve me. And another example of how we can address stigma, and it was mentioned earlier, is with routine opt-out testing. If every time you go to the doctor, they ask you, they suggest a HIV test, as opposed to asking you questions about your sexual experiences, then it destigmatizes an HIV test. If everybody, I don't care if you're a 65-year-old grandmother or 18-year-old freshman in college, if everybody gets to a point where you just expect it to be tested, then it really does normalize the experience. I'm sorry for being so long-winded.
No, this was great. And yes, you are beautiful. 50 years old. It's true what they say. I won't say it here, but you know what they say.
Right. They know.
Yeah, thank you for that. And that actually, what you ended with, kind of is a great segue into a question that I have for maybe either Eric and Arkila, is that I feel like stigma is not just something that the community is doing and perpetuating. I think stigma is also amongst the medical community. So just like you said, just like we go into the doctor and they say, let me check your blood pressure, your iron, your vitamin D, why isn't the HIV test just a normal part of that routine care? And it's interesting. So I do get my HIV test at least once a year, and I always have to sign a paper that says that I am giving them permission to do this test. And I think that it's just the most oddest thing that there is. But Eric and Arkila, that graphic that you had on the last slide about these wraparound services, this care, how can we ensure that all primary care providers and the broader medical community is on board with caring for the whole person, regardless of their sexuality, regardless of how many partners they have, but really understanding the importance of that graphic and bringing that graphic to life for everyone?
So I'll start and I'll let Eric add on onto what I'm about to say. And that's a good question. And it starts with educating, because we're so used to educating the community that sometimes we forget to educate ourselves. So I will say that just like Dr. Rayford just said about representation. So the stigma still lies because you have providers that, they're human, so they will have certain biases. And I have heard stories of women who have asked for STI tests or HIV tests, and they were asked multiple questions that made them feel uncomfortable. So the education starts. So those of us who work in this environment and in this specialty, it's important for us to go out and to educate those members of the healthcare profession that do not normally work in this type of environment. And I'll be honest with you, there are some healthcare clinicians who are not comfortable doing sexual health education. They're not comfortable asking those sexual health questions. And talking about representation, I will say that I remember when a celebrity came out, Tamar Braxton. She came out and said, "Hey, I am taking my PrEP because, it's scary out here." And I remember the backlash that she received. Okay. And this is a well known artist who said that she was on PrEP, received all this backlash. And it just goes to show if she had to endure that, then what would the everyday Black woman encounter if she was to go into her doctor's office that is not comfortable with taking a sexual history or providing sexual health education? What would she be greeted with? So I do believe that I'm going to say, and I'm going to let Eric take it over because he has worked with primary care physicians and helping them to provide HIV opt-out testing with the patients that they care for. But I will say that it starts with educating ourselves. Eric, would you like to add to that?
I mean, I think you nailed that, as you always do. Thank you, Arkila. I will add a couple different things, right? I think we got to understand the history and how we got here, right? When HIV was first discovered, one of the first public names that it was given was gay-related immune deficiency syndrome, right? So it was immediately pinned to a minority community that didn't have a unified voice, that didn't have a broad voice. And then as HIV developed, and you saw this on some of these slides, right, the treatments were really complicated. Like we started off with like 15 pills in a day. There was a specific way that they needed to be administered. So treating HIV was a broadly complicated topic for a very, very long time. And that's really only recently changed in the last decade or so. So it is on us to re-educate ourselves, to continue to educate ourselves, how what Arkila specifically said. And to the story of the testing, right? Grady is a leader in this. So we actually perform over 60,000 tests, HIV tests per year in our communities. And we do it on an opt-out basis. So we do not go to a patient, and we follow Georgia law on this, right? We do not go to a patient and we say, "Hey, would you like to have an HIV test today?" Because that requires our patient to already be educated on what that means. And for most people, they think, "Oh, HIV, that's a gay thing. That's like a thing that like the bad people get," right? And that is the essence of stigma, is how we think about others. And so I think the moral judgment is a really, really big problem when we talk about HIV, when we talk about STIs. We don't treat any other viral infection or bacterial infection, even in comparison to what HIV as a virus is. We don't treat any of them this way. So it is on us to continue to educate ourselves, but also to equip our community with good information so they can advocate for themselves and recognize when they're not in good hands, and then provide them with the tools to recognize like, "Hey, you know what? This didn't work out too well over here. I'm going to go to Grady, or I'm going to go to Positive Impact, or I'm going to go to Aid Atlanta, or I'm going to go to," there's so many phenomenal organizations here in the Atlanta regions. Someone Cares, Here's to Life, so many phenomenal organizations. And it's important that we have that plethora of services, because if you take anything away from this presentation, from the two slides that I could speak on, is you need to have a care environment where you feel represented, where you feel heard, where you can ask the uncomfortable question that is uncomfortable for you to ask, but not be given an uncomfortable answer. And if that is not what your care team can provide to you, then reach out and let's provide better resources.
I love that. And thank you both for your work. I think it's commendable. And what I really appreciated about the presentation is that you talked about what you have been doing, and then you also said that there's still more work to do. So I think that's also a great takeaway, that there's progress, but there's still more work to do. Timim, let's get you on stage here. Your story was so beautiful. And as a mom of young people, as a Black woman, my heartstrings are always pulled when I hear about young people not being feeling loved, or they're struggling, which in some respect is just natural. You know, we all have a sense of, we all want a sense of community. We all want a sense of belonging, and those feelings are absolutely valid. What I hear, my question is about creating a safe space. So when you were telling your story, safety came to mind. Not only safety from back then when you were 19, but also safety today. When you think about creating a safe space in your work today, what do you do to ensure that not only young people, but also your peers have that safe space to feel included and loved?
I love the conversation about normalizing and universalizing these topics. I created a program that was the intent was to support LGBTQ youth in schools. What we decided to call it was You Belong, YOU with the TH in parentheses, belong. And we did that for a reason, because not all kids are even out to their parents. I certainly didn't have that conversation with my parents when I was, in high school a long time ago. Of course, that happens a bit more today, but the reality is, and in particular for those who, you know, um, there are a lot of stereotypes that we hold on to in our community around what gay looks like. And I was one of those kids that felt like I was a unicorn because I was the captain of the basketball team and I did all the hip hop. Like I was the penultimate masculine dude. And yet I was like, something's different about me. And I really can't share it. I even envied the gay boys that found each other because at least they had community. Right. And so for me, I think it's like we have to really open our eyes, create spaces where we don't make assumptions about who could be on that side of the fence. Sexuality is fluid, it evolves over time. And I think we just need to have a better understanding of that. And if we are providing an environment, I think of it this way: if you're providing an environment where LGBTQ Black kid is safe, then other people should be safe as well.
Absolutely.
And I think if I mean, it helps everybody. And when I used to go into schools and I was like, oh, this is a school that's unsafe for LGBTQ kids, I was like, well, it's probably unsafe for a lot of other people as well. And so I think universalizing, normalizing spaces where we can all feel safe is a benefit to all.
Absolutely. And we've all talked about stigma. I think everyone touched on it a little bit in their conversations. Do you think stigma has decreased over the past 30 years? How has it changed for you, and what work is there still to do?
Really, it's a really interesting question because I go back and forth. I think there's more tools, resources, there's prep, there's all this stuff out here, and yet I've personally been the victim of talking to somebody, and then 3 minutes later, like a whisper happens and he's sick or he's not clean, or these words that we use that are very dangerous and stigmatizing. And I'm just like, if you are a Black, gay, queer man in Atlanta, the likelihood that you have already been connected to someone with HIV is very likely. And so I always find it kind of ironic that you still have that level of stigma in our community, and I think it's even harder in communities where it's not talked about as much. So I think when I talk to my Black women friends, it's like, yeah, there's a stigma around even having that conversation, because what are you admitting if you're a Black woman talking about HIV prevention, right? Are people going to stigmatize your sexuality or your promiscuity or anything else? And so I think, again, we really have to continue to address it, because it doesn't make sense when you equals you, and when an undetectable person, you've seen the evidence and the stats that when people are virally suppressed, they cannot even pass on HIV. So we
Mhm.
should be talking about it more. There should be less stigma, but I don't know that that's always the case.
Right. And before we open it up to the questions in our chats, I do want to stick with Black women a little bit longer. So when we were talking yesterday, you said something really profound to me, because a lot of Black women, especially if you're married, if you you think about trust, and so many people might say, well, I'm married or I'm in a committed relationship. What is your view of trust and taking care of yourself, regardless
Yeah.
of what you may think you have in your relationship?
Yeah, I had to learn that the hard way. I was in what I thought was a committed relationship with someone when I contracted HIV. And I think quite often it's, that idea of like someone else didn't protect me, right? And I think that one of the reasons that I do so well with my HIV is I eventually had to take ownership that like I made decisions that I trusted someone else to make decisions about my body. And so with you having PrEP out there, with you having the ability to ask to get tested, that's for Black women or anybody else saying, I'm going to take this in my own hands. I'm not going to leave it to another person to make those decisions for me. And I mean, that's it. We want to be able to trust, but at the end of the day, like, you have to protect yourself. And I don't think anyone should ever be apologetic for deciding to put themselves first.
Absolutely, unapologetically putting ourselves first. Yeah. Well, you can stay here for a moment. There was someone in the chat that says, "Thank you for your powerful story, Mr. West. I truly appreciate your transparency and your mention of the significance of trust. How can public health leaders and public health workers build more trust with people living with HIV?"
Yeah, I really think it's an approach when I go to physicians and I go to clinicians and therapists, and you can tell when someone has those biases. You can literally feel it when you walk into the space. And as I kind of said, my best health outcomes happened when I had care and treatment that when I walk in the room, so good to see you. How you doing today? Right. I even had a doctor one time that asked me, are you dating anybody? Like, what's going on? Like, it kind of made me feel normal, right? They didn't put my dating life and my sexuality to the side. They kind of asked about it and made me feel whole. And I think that's really important. If the only time as a clinician or a social worker that you're engaging with HIV is when you're dealing with patients and you haven't dealt with those things outside of that space, it shows up. And I think for the people that I know who are physicians, clinicians, social workers who have people in their lives and family and friends who are impacted, you can also tell as well because that interaction is so normal and organic for them.
Mhm. Awesome. I think I lost my questions. Okay, here we go. They're back. There was one other question in the chat, and anyone can answer this. I thought the only way that you could receive HIV treatment at Grady, so perhaps Eric and Arkila, was if the person had a viral load under 200. Otherwise, they wouldn't qualify for HIV treatment at Grady.
So, Arkila, are you okay if I speak on this a little bit? All right.
Yes, go ahead.
Authorization by the boss. Thank you. So as I said earlier, and I'll make this a quick answer, but as I said earlier, it is about us building ourselves and our own systems in the way that work for our communities, right? So for the very long time, the Grady Ponce de Leon Center, formerly known as the Infectious Disease Program, has been in place since 1993. And so we've been committed to the Atlanta community for a really, really long time. But we also recognize that the services that we provide here, the level of complexity we can provide in regards to the specialty of the care, is one that more folks need than just the folks that are basically below 200 CD4 cells. Just for everybody watching, if a patient falls below 200 CD4 cells, that measures, broadly speaking, how strong or healthy your immune system is. Generally speaking, that can become an AIDS diagnosis, right? And that's a word, that's an acronym. We're happy to discuss more broadly, but I want to keep us centered on HIV. We changed this rule in 2022 because we needed to make sure that we showed up for our community, and that was also part of the reason why we brought our HIV prevention program over into the Ponce de Leon Center. Because one of the things, and we spoke a lot about stigma, but stigma also happens when we as a community talk. So what happened to the Ponce Center, everybody in the Atlanta community knew what the work was that we were doing, but people would drive by and be like, that's the AIDS building. That immediately stigmatized our patients, and it made it an emotional barrier for our patients to feel comfortable to walk in and say, hey, I need Grady to show up for me. So we had to change ourselves. So from opening our doors more broadly to onboarding HIV prevention to decentralizing was all about how do we show up better for our community. So if anybody in Atlanta is looking to or is needing to get into care for HIV or is looking for HIV prevention, feel free to come to us, and our staff, our phenomenal team that I am so honored to support, will absolutely sit down with you and figure out where is the right place for you to go, right? Is it us? Or maybe there's a clinic that's barely half a mile away from your house that you could go to. Maybe you're looking for a service that we might not be able to provide, but we have a great community partner that can do that. For us here at Grady, it is never about holding on to a patient and say, you're our patient, you must come here. It is about doing the right thing for our patients. So if all we can do is to support you to find a good care home that can provide for you what you need, then it'll be our honor to serve you.
Awesome. There is another question, and it's related to governmental policies. It says, which governmental policies do you believe would go the furthest to advocate for HIV prevention and HIV management? And perhaps that might get some input from Dr. Rayford as well. We can start with you guys if you like.
All right, go ahead. Excuse me. So the whole time that I've been listening to the various panelists speak, my heart, is there for everything that I'm hearing, but I also want the public to know how much your CDC scientists understand all of these things. How do I say this? The CDC had up until last year about 13,000 employees, and we have various centers that do various things. I work in the center that focuses on HIV, viral hepatitis, tuberculosis, and STD prevention, as well as HIV prevention. And I can say that my center, particularly the Division of HIV Prevention, is the most diverse and caring group of people that you will ever meet who work for the federal government. And we're all very passionate about eliminating stigma, about wrapping services around individuals. All of the things have been talked about today. And we have programs, so many programs dedicated to these various things. So to answer the question, we actually have the opportunity to make the difference. The issue is that we are federal agencies, so when the administration changes, things change. Let's just put it that way. And so right now, for example, we have all of these programs, but we don't have a communications department to be able to get that message out to the community that these programs exist. And so we're a little hamstrung. But another way I'll answer the question is to say that I would beg to say that stigma is the number one issue that we really need to get a handle on if we're ever able to take full advantage of all of the resources and tools that we have at our disposal at this time. And that's a huge ask. That's huge. That and knowledge and awareness, but really stigma, because you can address it in so many different ways. But we have to have the political will to do that.
And that brings up another question or thought that I had is like, how does the current political climate, how has that impacted your work? And I believe it was in the Ponce clinic's presentation, you talked about funding instability. And so how does that impact your work? And I mean, you all are still doing it. So obviously it makes it harder. Tell me more about that.
Arkila, you good if I speak a little bit, or you want to go first?
Well, no, you go ahead because you're the one that works with that. I'm on the floor. So you're the, you're the
You're
one
one of
that's
the
working
early
to bring in the
advocates.
money. So what I'll do is I will say that, the Ron White funding has, been, flat funded for the past 10 years. And Eric has been working diligently to make sure that we have the resources that we need, to not only to take care of our patients, but to have staff to take care of the patients. And Eric, I'm just going to have you just to take it from there and to tell them about all the wonderful work you've been doing.
That we've been doing.
That we've been doing. That's right. That
Team,
we've been doing.
I think it takes more than a village. It takes a whole.
That's a nice setup.
Exactly, exactly. So I think, and Timem, you hold me honest on this because I know you're doing this on a national scale too. So, Monet, if you're cool with it, I'm going to jump back to your last question because I feel like not everybody can speak quite as freely. Number one, if we want to talk about policies that are important to our communities, as Arkila just said, Ryan White has been flat funded for well over 10 years. The 2027 fiscal budget proposal would cut $1.5 billion from HIV care, prevention, substance use, housing programs, and otherwise. We have told you all about housing, housing, housing. If I have a patient who has fallen into a drug use situation, until I can get that patient housed, it's incredibly difficult to help that patient find a path to their own well-being, right? To empower them. So number one, federal policies, or broader than that, don't cut our funding. We need more funding. The reality is delaying HIV care by literally, if you look at like 3 years, if we can diagnose somebody within 3 years of exposure, lifetime treatment costs about $360,000. If we're delaying that by about 10 years, we're looking at $1.5 million lifetime treatment cost. It is fiscally responsible to increase funding to HIV prevention, testing, and treatment efforts because ultimately it saves us, the taxpayers, incredible amounts of money. Right? So number one, don't cut our funding, invest in us because we're here to put ourselves out of business. We don't want to continue to have to provide care to HIV, to persons and living with HIV and new infections. We want to help our patients get healthy, get well, and to not be dependent on that support, right? That is really crucial to the work. Number two, let's talk about Medicaid expansion here in the state of Georgia. If we truly want to make an impact for our most vulnerable communities, then it is all about increasing access. And that means enabling our patients to access these medications that can cost $5,000 a month, $15,000 a month, $25,000 every 6 months, right? It is crucially important that our patients have access to these medications because it provides an incredible savings on the fiscal side, but it's the right thing to do. And that's one of our Grady core values. It is do the right thing, right? And the right thing to do is to help our communities. Beyond that, on a federal level, we should have universal sexual health education in our schools. To think that we have a population that is so impacted between the ages of 13 to 24, and if you broaden it and you say 13 to 34, over 50% of all new infections in the country occur between the ages of 13 to 34. We can change that. We can help our communities access that. And beyond that, housing, invest in housing, give people the dignity of shelter, of support, of the ability to receive their medications in the mail in a place where it's safe, be able to store the medication in temperature ranges and beyond. So advocacy, education, outreach, and awareness are so crucially important. And if there is anything that we can say that anybody wants to hear tonight, it is not only the right thing to do, but it also saves money. And if that's all you care about, we all care about saving lives, right? And we want to save communities. So let's do that. But if it's about the money, the facts are on our side. Invest in us. We are committed to helping our communities be well.
Yeah, and I would add a little bit of a soapbox. I just returned from the National Civil Rights Museum in Memphis and was shown the new gerrymandered Tennessee map. And it will be really interesting to overlay HIV prevalence and incidence in the state of Tennessee with the gerrymandered map, which not only represents like just voting, but we are voting for certain kinds of things, right? And so when you dilute a population of people who've had some ability to mitigate some of the harm that could happen because of the concentration of HIV prevalence in certain of our areas, and then you take away their ability to actually care for themselves, you know, that's really terrifying to me, right? And I don't put it past other places to see that as a roadmap for splitting our districts in Georgia and making sure that there's less power. I think we have some of the gains we have because Atlanta, relatively speaking, has become a much more inclusive and supportive arena. But that could change. That's not forever. And if there's anything that we've learned about politics, is that just because things got to a certain place doesn't mean it's going to stay that way. We have to remain vigilant.
And we have to defend the progress and hold on to it.
Right. Is there anything, if you had to cut one strategy, what would it be and why?
Cut a strategy, like remove a strategy?
Are there any strategies that are more effective than others that if you are impacted by the funding and we're not able to kind of touch on all of those things that you mentioned, is there anything that we should do any less? So that the answer is that we have to keep doing all the things, right?
Yes.
Okay.
I certainly think we could do more. I just don't like. I think
Yeah.
everything that's being done is good. I think there are some other strategies. I talk to Gen Zers and alphas now, and I just think we have to take note of AI and social media and all these innovations that young people have. How do we utilize those systems to impact the rates of HIV/AIDS? So I think that's more though. That's more on top of what we're doing now.
Yeah,
Right.
we definitely can't cut anything because it's almost like a tool. It is a toolkit, and if you cut this one thing, that may affect one subgroup versus another group, and so if you might downsize, meaning you can't do as much of a thing, but I don't think you can cut any one thing.
I agree. I don't think that there's one thing that should be cut, but I also want to throw in, I like how Tim talked about using AI approaches, but also expanding mobile health access as well to go out to reach the community. I think that that's very important as well for those individuals that have a hard time coming into the clinic, maybe, transportation issues, or maybe they just don't feel well enough to get up out the bed to come into a clinic to receive their care. Maybe we can go to them to provide patient-centered care.
Yeah.
I'll also say that one thing about, well, I'll just say Black people specifically, is scarcity has always driven creativity. And so, I mean, we try to do as much as we can and always have, even if we have to do it with less. And so we do find ways, but of course, ideally, we just have the funding that we need.
Right. All right. Well, thank you for such a rich discussion. I'm going to ask each of you if you can put in how we can contact you in the chats, whether that's LinkedIn, your websites, your socials, your organization's information. I do want to let Tim in. If you can give me like 10 seconds of the Portia show. Are you going to be a guest on Portia soon? Oh, you're on mute.
I just got word today that something that was recorded some time ago, we will be on the Portia show on Monday. It looks like in Atlanta, 1 to 1:30 on Monday. So hopefully someone that has a recorder can record it. And I don't sound silly, but it's a great show. And it's a really good, I think, complement to what we talked about today. So definitely check out Portia on Monday in Atlanta at 1 to 1:30 Eastern.
All right, awesome. Again, thank you all so much for the work that you do every day, and thank you so much for being here. I'm going to turn it over to our chapter president, Tamara Trammell. She's going to close us out.
Thank you so much. As we wrap up today's session, I'd like to thank each of our panelists, the committees that worked hard to bring everyone together, Sarah Monet, Dr. Wimberly, and the audience who prioritized attending. Please fill out the survey using the link or the QR code that you see on the screen here. And while you're doing that, I want to leave you with 3 essential takeaways. Number 1, HIV does not discriminate. Anyone, any background, any lifestyle, any community can be impacted. Second, get tested at least once a year. Knowing your status is one of the strongest tools you have. And if you are living with HIV, treatment today allows you to live a long, healthy life, build a family, and even have HIV negative children. The science is real and the support exists. Third, don't keep this information to yourself. Share what you've learned today with your friends, your family, your group chats, your circles. Knowledge saves lives. Thank you so much for showing up, for caring, and for being part of a community that leads with truth, empathy, and action. Your voice and your choice make a difference. Thank you so much for attending.